Okay, so we will continue with colorectal cancer. Colorectal cancer, or cancer of the colon. Cancer of the colon, right? So cancer can affect any part of the body from the head to the toe, right? So it can affect any part of the body, the eyes, the breast, everywhere, right? It can also affect the colon, right? And we know that the colon is part of the GIT, right? So it's the we have the small intestines and the large intestines. So the colon is the large intestines. We have the ascending colon, the transverse colon, and then the descending colon, right? So cancer can affect the colon as well as the rectum, right? So abnormal proliferation of the cells of the colon and the rectum is what we term as colorectal cancer. Colorectal cancer. Colorectal cancer is the second most common cancer in women after breast cancer, and is the third most common in men after lung cancer and prostate cancer. So it's the second most common cancer in women after breast cancer, and the third most common in men after lung cancer and then prostate cancer. Worldwide, it is the third most common cancer, and then the fourth common cause of death, right? So it's one of the conditions that is killing many people worldwide, right? So worldwide, it ranks third, right? And then in case of mortalities, it ranks fourth. And then in 2007, it was established that 99% of the cases of colon cancer cases occur in people who are within the age of 40 and 85. So it means that mostly it occurs during the old age, right? Between 40 and then 85, right? And then in those more than 60 years, okay, so most GIT cancers occur in the colon, right? So from the mouth, the esophagus, the stomach, the small intestines, the large intestines, and the accessory organs like the liver, the pancreas, right? Cancers of all these organs, majority of them occur in the colon, right? Majority occur in the colon, and about 2/3 of these cancers occur in the rectosigmoid area, right? So getting to the colon, the end of the colon, joining the rectum, right? That is where most of the time it occurs. The risk factors, things that increases the risk of individual to colon cancer, include high intake of fats, or fatty foods, right? So high intake of fats or fatty foods. So taking in food rich and taking in too much meat or food high in calories, right? High in calories, and then food low in fiber. All these can increase your risk to colorectal cancer. And then aging 40 years and above, right, can also increase your risk. And then family history. If your relatives, especially your mother, father, or siblings are having it, your chances of getting it is high, right? And then some benign growths of the colon, like polyps, right? Colon polyps are the colorectal polyps. And then inflammatory bowel diseases of the colon, people who smoke, takes in alcohol, obesity, and then personal history of colorectal cancer. These are risk factors for colorectal cancer. Sites where colorectal cancer can metastasize to include the liver. That is the most common. So if it spread, the first organ that it can spread to is the liver. And then other organs are the lungs, kidneys, and then bones, right? Okay, so how would you know that someone is having colorectal cancer? Right, it's part of the GIT. So most of the time the person either have constipation or diarrhea, right? And then there can be a ribbon-like stools, right? So the stools shapes like a ribbon, right? So ribbon-like stools, and then bright red blood in stools. This one is not dark tarry stools, right? The old blood, but this one is bright red blood in stools, right? And then the person become fatigued, especially when it's getting to the advanced stage, right? Where the systemic signs comes in. So there's weakness, anemia, or fatigue, right? Sometimes there's abdominal pain, and then there's a sensation of incomplete evacuation of the bowel, right? So after defecation, they feel like they should still be on the toilet seat because they feel like the bowel is still not empty, right? And then palpable right side lower abdominal mass, right? So these are the signs and symptoms. If it's rectal cancer, then most of the time there's straining on defecation, there's incomplete evacuation, sometimes there's mucus discharge, right? And then there's bright red bleeding as the first one, and the person will have pain when it has advanced, right? Okay. I've talked about the site, I've talked about the signs and symptoms. Diagnostic investigations, most of the time, because it's close to the anus, we will, most of the time, the diagnostic tests include colonoscopy, right, or sigmoidoscopy, and then sometimes you can also do barium enema, right, not barium meal. Can do barium enema. Sometimes CT scan can also be done, right? And then ultrasonography can also be done, right? And then I've talked about barium enema, CT scan, MRI, ultrasound, all these can be done, right? Okay. It is recommended that men above, especially around the age of 50-40, should go for a test, right? So it's recommended that they go for a test so that the sigmoidoscopy and other tests too, so that if the person is developing cancer, we can detect it early. It can be detected early, and then treatment can be initiated early. So the American Cancer Society recommend that at the age of 50, there should be an annual fecal occult blood test, FOBT, annual fecal occult blood test at the age of 50, right? And then one of the following can also be done: sigmoidoscopy, etc. Right? Okay. And then the American College of Gastroenterologists also recommend that at the age of 45, every man, especially African Americans, should go for colonoscopy, right? So you go for it at the age of 45, and then every 10 years you go for it. And after the age of 50, so 40, around 45, 50, every man should go for colonoscopy, right? And then American College of Oncology and Surgeons recommend that at the age of 50, just like the American Cancer Society, annually every man should go for fecal occult blood test, and then accompanied by digital rectal examination, right? And then sigmoidoscopy should be done every 3 to 5 years. Okay, so it's important around the age of 40-45 as a man you go for these tests, right? Okay. Pre-op preparation is the same as all the GIT pre-op preparation that we talked about, right? So I'm going to talk about only the additional ones, right? With colorectal cancer, right? Removal for removal of the colon, right? Part of the colon. It depends on the part that is affected, right? So with that, we can do, most of the time we start the preparation 2 to 3 days to the surgery, right? So the preparation is started 2 to 3 days to the surgery, right? So within this time you can start with light diet, right? So from the second day you can start with light diet, right? And then a day to the surgery you can give fluid diet, and then 6 to 8 hours to the surgery the patient is maintained on Neoper or snatting by mouth, right? And then enema should be given as prescribed, or laxatives, right, to clear the bowel, right? So you want to clear the bowel, and with this condition, even if the patient has eaten within the specified time, sometimes NG tube is passed to decompress the stomach, right, to drain the contents, right, so that the patient can be taken to the theater, right? And then we also have to do rectal washout, right? Most of the time you have a solution with antibiotics, and then you used to wash the rectal area to get rid of or to reduce bacterial contamination, right? And then after the surgery, sometimes colostomy is created, right? So if colostomy, I've already talked about colostomy, so I'm not going to talk about it again. If colostomy is created, you know how to manage it, right? And then I've talked about rectal or colonic washout, and then NG tube might be passed. I've talked about that, right? And because it's cancer, sometimes chemotherapy is started before the surgery and then after the surgery, and then you have to also ensure perineal hygiene before the surgery. The other general pre-op holds. Let's look at the post-op for colorectal cancer. Post-op, sometimes a wound drainage tube, the patient might come with colostomy, right? I'm not going to talk about colostomy again because I've talked about it in the previous lecture, right? And then patients may come with a wound drainage tube, and you have to manage it, right? The drainage tube, right? And you know how to manage drainage tubes, right? So ensure continuous drainage, the amount, the color, the consistency. Ensure patient is not lying on it. The tube is well secured. The drainage bag is below the patient, not on the floor, right? To ensure flow by gravity. And then incision site, there are no drainage or bleeding around the incision site. You give prescribed pain medication, antibiotics to prevent infections and all that, right? Nail per os may be maintained, right? Because after removal of cancer of the colon, sometimes it may be maintained, usually between 3 to 5 days, right? And then patient is most of the time discharged 10 to 12 days after the surgery. And most of the time, perineal wounds take time to heal as compared to other wounds. It may take about 2 to 4 months to heal, but you have to do your wound dressing, right? Okay. And then sometimes if you are dressing the wound, you have to irrigate the wound, right, with normal saline and antibiotic solution to prevent infection. Prescribed analgesics, antibiotics are given, right? You assess the pain, the level of pain and all that, right? So that will be the end for colorectal cancer. We will talk about pancreatitis, and then in our next lecture we are going to talk about pancreatitis. You can read on it before our next lecture.